Bismillahirrahmanirrahim. Yeah, I'll try to be fast, and perhaps we can finish in 15 minutes. So to start with, hypercalcemic or hypercalcemia by itself, I've taken one emergency only, and I think it will be nice to focus on one of this oncological emergency, which is hypercalcemia of malignancy by itself. So we will be speaking about the prevalence of hypercalcemia emergency, hypercalcemia of malignancy, the severity staging of hypercalcemia of malignancy, the clinical manifestation of hypercalcemia in malignancy, the differential diagnosis, the pathophysiology of hypercalcemia of malignancy, the investigation that needs to be done, and the prognosis of it, and what management lines that we need to perform for the patients. So this is a study done on different types of cancers and the association of hypercalcemia in these cancers. I thought it will be more vigilant, but if you can see here, it is most common in certain types of cancers that can have hypercalcemia by itself, and it's not in all types of cancer. It's mainly in myeloma, as it's part of the diagnostic criteria. It is within the lung cancer, renal cancer, and lymphomas. So more in solid tumors than in leukemias. So throughout the years, you will see that this is a prevalence of 4 years or 5 years in sequence. The prevalence of hypercalcemia in those malignancies are almost constant. So as we said, it's more on solid tumors, breast, lung, renal cancer, and multiple myeloma. The severity of staging, actually, there is 2 staging severities. One is looking into it as mild, moderate, and severe. Mild being serum calcium, or corrected serum calcium being below 12. 12 to 14 is considered moderate, and above 14 is considered severe. As part of the National Cancer Institute, they have also graded it according to 4 grades. So if the serum calcium is above the normal limit of to 1.5 initially, and if it's between 1.5, so between 11.5 to 12.5, that's considered grade 2. Grade 3 is considered between 12.5 to 13.5, and above 13.5 is considered grade 4. And we need always to make sure that this is the corrected calcium to albumin levels. The clinical manifestation are related to the severity of hypercalcemia of malignancy, the rapidity of the calcium breach, and the presence of bone metastasis. The clinical manifestation of hypercalcemia of malignancy is a general manifestation that happen in any case of hypercalcemia. So we do have the neurological manifestation, which is the muscle weakness, the fatigue, the hyperreflexia, the apathy, the disturbance of the perception and behavior, the lethargy, the stupor, the coma. The more severe the patients, the more severe the more severe the calcium and the rapidity of it, the more severe are the symptoms. The renal manifestation of hypercalcemia, which is polyuria, polydipsia, volume depletion, which most of the patients with hypercalcemia of malignancy, because it occurs as a rapid occurrence, they develop renal impairment in association. So it is common for it. The more gradual hypercalcemia develop nephrocalcinosis and kidney stones, as in primary hyperpara and the other diagnosis. GI manifestation of hypercalcemia, the nausea, vomiting, the anorexia, the constipation, the ileus, the peptic ulcer disease, and pancreatitis. The cardiovascular manifestation is also important to look at because it's part of the mortality. So you have ECG changes, which include shortened ST segments and QT intervals, widened T wave, you have bundle branch blocks, you have second-degree blocks, you have bradyarrhythmias, you can have complete heart block, cardiac arrest, and at certain patients, hypertension. Pruritus is also a dermatological manifestation of hypercalcemia. So the causes of malignancy-induced hypercalcemia can be due to hyperthyroid, and it can be due to low parathyroid. So parathyroid hormone is an important initial investigation to differentiate the different types of cancer-associated hypercalcemia. So we have hypercalcemia with hyperthyroid levels. It is parathyroid carcinoma, which a characteristic of it is to have a very high parathyroid levels. Ectopic parathyroid production, we'll speak about it. It's a bit of a rare manifestation, but it can be there. And then we can have hypercalcemia with low parathyroid hormone. That can be, which is humoral hypercalcemia of malignancy, which is the most common, and it is 80% of the time that happens. The osteolytic hypercalcemia, and we will speak about the mechanism that it occurs with. And then calcitriol, or 125 dihydroxyvitamin D induced hypercalcemia, which is certainly occurs in lymphomas only. We can have other causes of hyperthyroid hormone and hypercalcemia, which is part of the differential diagnosis. Primary hyperparathyroidism, which sometimes can deceive us because of the X-ray images when it becomes in a chronic stage and they develop the Brown's tumor and the osteolytic lesions that can happen. So you should think about it. And this is the most, it and hypercalcemia of malignancy are the most common cause of hypercalcemias. And then it can happen as a parathyroid adenoma, where primary hyperparathyroidism is not always, or most of the time it's associated with hypercalcemia, but it can happen in normocalcemic patient, which is also a field that is being investigated in endocrinology, and at certain points we can also manage patients with normocalcemic hyperparathyroidism with a different criteria. Okay, it can also happen in hereditary hyperparathyroidism, which is MEN1 or MEN2, where we have MEN1 involving pituitary, parathyroid, and pancreas, and we have MEN2A actually involving the parathyroid, the thyroid as a medullary carcinoma, and the adrenals. Tertiary hyperparathyroidism is also associated with hyperthyroid levels and hypercalcemia. Hypercalcemia due to medication is very common also, so we need to look at it, where we have thiazide diuretics, where it causes less calcium excretion, and lithium therapy also as a medication-induced hypercalcemia. We also have familial hypocalciuric hypercalcemia, which is one of the differential diagnoses of patients with hyperthyroid and hypercalcemia, where it's characterized by decrease in calcium excretion. Some of the patients, because of the involvement of the CASR gene, the calcium sensing receptor gene mutation, which can be both in the kidneys and in the parathyroid, they can have hyperthyroid levels. The mechanism underlying hypercalcemia of malignancy is a bit varied. So we have humoral hypercalcemia, which occurs in 80% of the time. Bone metastasis is minimal to absent, and the causal is the parathyroid-related peptide. The osteolytic hypercalcemia, which occurs in 20% of the time, it's common and extensive. The causal agents are cytokines, chemokines, and parathyroid hormone-related peptide, and we will discuss in a bit of detail. The 125 dihydroxyvitamin D induced, which is mainly in lymphomas, and the ectopic parathyroid hormone production, which also we'll discuss it in a point. So humoral hypercalcemia of malignancy, it is mainly secreted by tumors, where it suppresses the normal parathyroid hormone. So you will have a suppressed parathyroid hormone, but an elevated parathyroid hormone-related peptide. The humoral hypothesis was confirmed, the Albright humoral hypothesis, which was confirmed in 1987. It accounts for 80%, as we discussed. It is most common in associated with squamous cell carcinoma of the lung, head and neck, esophagus, skin, and cervix, and carcinoma of the breast, kidney, prostate, and bladder. Both parathyroid hormone and parathyroid hormone-related peptides act on the same receptor, the PTH1 receptor, which is a G protein coupled receptor with 7 transmembrane spanning domains. And both of them induce the same signaling pathway that occurs. It activates a cyclic AMP and protein kinase A and C, and then that goes into phospholipase C, and then inositol phosphate. All of them, after this cascade, they will induce a rank ligand expression on the osteoblast, which in turn, upon binding to the rank receptor in the osteoclast, leads to further osteoclast generation and activation. So if we can see that that pathway will induce rank ligand production, and that rank ligand will act on the rank receptor on the pre-osteoclast, which will activate the osteoclast, and that activation of the osteoclast will induce the bone resorption. The local osteolytic hypercalcemia, which is account for around 20% of the time in malignancy-related hypercalcemia, which is characterized by increased level of phosphate. It suppresses the parathyroid hormone, and it has low levels of dihydroxy vitamin D. So the local cytokines are released from tumors that can stimulate local production of parathyroid hormone related peptides. So it acts only locally on the cells, which in turn induces rank ligand and rank interaction, resulting in excessive osteoclast activation, enhancing bone resorption and hypercalcemia, without increasing the serum level of parathyroid hormone related peptide. So local osteolytic hypercalcemia most commonly occurs in multiple myeloma and metastatic breast cancer, and less likely in leukemias and lymphomas. Excessive production of extrarenal 125 dihydroxyvitamin D is an ectopic production of 1-alpha hydroxylase, which induces the formation of or the conversion from 25 vitamin D to 125 dihydroxyvitamin D, which is increase in calcium and phosphorus absorption from the GI tract to increase osteolytic or osteoclast-mediated bone resorption. It's nearly exclusive in lymphomas, as we discussed, Hodgkin and non-Hodgkin lymphoma, and it is one of the poor prognostic indicators in calcitriol-mediated hypercalcemia. Ectopic secretion of parathyroid hormone is less common. It can occur in lung, ovary, sarcoma, and neuroendocrine tumors. So investigating a patient coming with hypercalcemia is to determine the calcium levels and the corrected calcium level. Then you need to send investigation for parathyroid hormone-related peptide, the phosphate level, the 25 hydroxyvitamin D, and the 125 dihydroxyvitamin D. So this is the graph, and we have discussed a lot of points in this graph, so we'll go through it fast. So hypercalcemia with hyperthyroid hormone. If the parathyroid hormone is elevated, you should think about parathyroid cancer. And if the other differentials, if the parathyroid hormone is suppressed, you do the parathyroid hormone related peptide level, where if it's high, you're thinking about humoral hypercalcemia of malignancy, and if it's low, you think you do the calcitriol levels, which is the 125 dihydroxyvitamin D. So if it is low, it is osteolysis. If it's high, then you are thinking about an ectopic production of 125 dihydroxyvitamin D. So the lab investigation that I think I will go through it because we need some more time in the management. So as a prognosis, although early series has reported a 30 days mortality of 50%, which this study was done initially in 1990. In 2015, there was another study that is done and showing a mortality decrement as we are improving in cancer management. And it's one of the managements of it and the improvement in the management of hypercalcemia by itself. So this is the presence of hypercalcemia can indicate worse prognosis. And this is a Kaplan-Meier survival curve over 10 years and showing the survival rate in patients with normocalcemia and hypercalcemia, but it depends on the type of cancer, the state of it, and the metastasis. Okay. So the treatment according to the Endocrine Society guideline, which we will go through. If you have mild hypercalcemia, as we discussed, adequate hydration, avoiding factors that can worsen hypercalcemia. If you have moderate hypercalcemia, you can go if it's a chronic or if it's an acute raise. If it's a chronic, then you need to see what is the cause of it, and the approach will be the same as in mild hypercalcemia. If it's acute increase, you go through IV hydration, you go through IV bisphosphonates, denosumab, and if it's severe hypercalcemia, you can go with aggressive hydration, denosumab, or bisphosphonates, and then calcitonin. And refractory have also a different management protocol. There is a special situations where we have hypercalcemia associated with high calcitriol level, where you need to have adequate IV hydration. Hypercalcemia due to parathyroid carcinoma also requires treating the underlying cause and initial management with bisphosphonates and or denosumabs. So IV hydration with normal saline, you need to give a bolus of 1 to 2 liters. Then you need to give 200 to 500 ml per hour of normal saline, and you target a urine output of 100 to 150 ml per hour. Steroid is given in hypercalcemia of malignancy, 200 to 400 milligram per day divided over 3 to 5 days, or you can give oral prednisolone. Calcium mimetics like cinacalcet is mainly in patients being treated with parathyroid carcinoma, where it will act on the Caser receptor gene and the parathyroid hormone, and it will suppress the parathyroid production. So this is part of the management of mainly hypercalcemia related to parathyroid carcinoma. Bisphosphonate, we have xylindronic acid and pimodronate, which is a nitrogen-containing bisphosphonate. It inhibits resorption by inhibiting the FPPS within the osteoclast to cause osteoclast apoptosis. They also interfere with osteoclast recruitment and function. So we will go over it. Pimodronate, the dose of 60 to 90 milligram, given over 2 to 24 hours, and it can be repeated every 2 to 3 weeks. The action takes 7 to 14 days to act, and it lasts around 2 to 4 weeks. Zoledronic acid is 3 to 4 milligram, and in certain guidelines, they will give 5 milligram IV. So these are the studies that is done. Zoledronic acid has an absolute reduction of 20% and a relative reduction of 40%, with at least one skeletal relevant event compared to placebo. In comparison, zoledronic acid is considered a better choice than pimodronate. Denosumab is ranked.
You can just please summarize.
Yeah, sure. Denosumab is a rank ligand, and it acts in a better than other bisphosphonates. Okay. So our take-home message is that we need to understand hypercalcemia of malignancy, as it is one of the malignancy oncology emergencies, and we need to reach to the diagnosis where we need, after reaching to a diagnosis, give the appropriate management for it. Thank you for listening.